if we go to the first slide to update you where we are. So it's been a busy year. We now have 34 sites open to recruitment, and recruitment has been good these last few months in particular. So we're now over 510 patients have been randomized into the trial. So that's a large number of patients. So a lot of hard work's gone into that. So really appreciate it. Thank you. You can look, if we go to the next slide, and see those sites that have opened. We had 19 open this year. Obviously, we were hoping to get more open, but it's great to get these 19 sites open. We still have a number on the list that hopefully will open early in 2026 as well. So welcome to all the new sites, and many of you have come in at full speed, hit the ground running, and been recruiting really well. So thank you. If we go to the next slide, we can see the overall recruitments over the whole duration of the trial. 119 is our actual total right now. Obviously, the people at the top of the list are those, you'll notice they've got their lower numbers. So that's you can see they've been in the trial for longer. So well done to all of those sites who've had that sustained recruitment over a year and a half, nearly 2 years now for some of the Imperial sites. So it's great to see those large numbers, but I really appreciate all those sites coming in. With the higher numbers, inevitably are at the lower end of this table, but it's great to see that recruitment. There's a few still to get off the ground, so hopefully there's a little bit of time in 2025, if not early in 2026. If we go to the next slide here, yes, you can see this is the recruitment by month per site over this last year. So you can see a number of sites recruiting very well. I think looking through, congratulate my own team at St Mary's. 2 months where we had 6 patients recruited in a month. So the team, well done. I recognize you in front of everybody as well. But I also appreciate all the great recruitment that's gone on, particularly as you see this last few months. There's a number of, I should say Bristol had the highest. Apologies to Jeremy and team at Bristol. You've had 7 and 6 as well, and 5 and 4. It's just been fabulous to see that great recruitment at your site, but other sites there, 3 patients, 4 patients. We were aiming for 2 per site per month. We don't hit that across the board, but you see it is possible. So particularly as we've got in out of the summer period, we've seen that high recruitment, and October was the highest recruitment to date with 57, and December, I expect it will get quieter over the Christmas period, but again, we've been having a reasonable recruitment this month. So please keep it up. We just thought we'd show you a few measures of trial processes. I realize you're busy recruiting, putting people into the trial, and you may not know what's going on in the trial. So this is a little bit of the trial processes that were extracted from the open report that goes to the data monitoring committee. We obviously, as investigators, don't get to see it by group, but these are sort of some of the pooled data or our simple process measures. So we know, are we delivering the trial well? And I think on general, we are. Some measures here about the diagnostic part of the trial. You see, looking at the PCT results, we've got 91% and 88% of the PCT tests taken exactly as per protocol on the days that we suggest. It actually might be higher. Obviously, on an ongoing trial, whenever a data extract is done, there's always data that's incomplete. So if you added in the missing data, if we're going to be positive, say it may actually have been done, it could be as high as 99% compliance. It probably isn't, looking at it. There'll be 1 or 2, but just to remind you to try and remember to take, if they're in the intervention arm of the diagnostic part, to take that PCT on the day of randomization, or if they've had one just done the day before, for instance, that can count doesn't need to be done again. Thought you might like to know a little bit about the PCR results that you send off. You'll obviously get the results for your own individual site. And overall, the number that are coming back as positive is about 64%. So roughly 2/3 of the samples, which I think is about right. If you think of whether we're more standard microbiology results that in studies, that's often around about the 50% or less. So 64% is higher, so hopefully it's more informative. Obviously, you could say, well, should it be 100%? Well, I don't think so. One, because we know the whole point is that some patients probably aren't infected. And also these tests, nothing is ever 100% effective. And there's always a concern with these PCR, could they be overly sensitive? So if we were seeing results up in the 90%, I was worried we might be picking up potentially false negatives. So this is probably in the region we were expecting. Importantly, in those cases where there is a positive PCR result, in just under 60% of those cases, you guys have changed antibiotics. Obviously, in the level of detail we're doing in this large pragmatic trial, we don't know exactly why you changed the results. But this suggestion that this is perhaps providing you with informative information and you're considering this in your daily antibiotic stewardship decisions, and something has happened on those days. There's been a change in antibiotics around that positive result coming out. So hopefully it is informative and informing clinical practice. Important is you'll know for the protocol, if you have both negative PCR result and the 2 negative PCT results, the protocol says that you should stop the antibiotics unless there's an indication, objective indication that antibiotics are definitely needed for some clear case of infection. They're relatively small numbers of these patients, but again, in over 2/3 of the time, you're stopping the antibiotics as per protocol. So well done. Thank you very much. We know it won't be 100% because, as we said, there could be reasons, objective reasons why some other test has come up as positive. For instance, I know that was the case at one of patients at St Mary's, for instance. They had other positive microbiology. And so, of course, we carried on the antibiotics to treat that bug. But again, it was good protocol compliance, I think. So we're happy with that. Please continue. The fluid part of the trial, we've got obviously the fact that we are randomizing to different fluid strategies. We want to know that there's a separation. It is a complex intervention, but we are seeing that separation. So at day 3, where we look at the fluid balance between the two arms, we can see overall there is more than 850 ml difference between the two groups. So the intervention group has a less positive fluid balance, shall we say. We'd set ourselves, we wanted to see at least 750. So 860 is good. Hopefully we continue that. Interesting when you break it down, because the protocol sort of tries to give less fluid or avoid giving excess fluid in the first place by making the objective criteria when you would give fluid. We see that is being very effective. Nearly 800 ml difference over that first 3 days, so there is separation there. But also, if the patients are overloaded and they're cardiovascularly stable, we try to start that de-resuscitation and encourage the fluid balance with diuretics. And there is a greater fluid output. It's not perhaps as much as we were expecting. It's only 110 ml on average. Obviously, this is the average across the patients. So some patients may well be more. Some may not be fluid overloaded and so don't need that diuresis. But just to encourage you to remember to think of that part of the trial as well. We're trying to remove any excess fluid once the patient is stable. So we go to the next slide. We were just looking at the outcomes. And if you all remember this trial, what we're doing is looking at the patient's status, clinical status, over the 90 days. So when we were talking with our PPI groups and was saying, what are the important outcomes you want from a sepsis trial, particularly diagnostic tests and how much fluid they got? They said, well, we want to know if it reduces mortality. We want greater survival, but we also want to get better quicker. And so what we do is measure the clinical state of the patient over time. So we have what we call these ordinal categories. And here you can see them plotted over time, where there are 4 ordinal states. And the worst state you can be in is obviously dead. Then we say the most severely ill group are those in hospital in the ICU receiving organ support. Improvement on that would be still in hospital, but not on organ support. And then we've got discharged out of the hospital. And you can see that over time. And so this just shows you for all our patients. So obviously we don't know the effect of treatment, but this is what those frequencies look like over time. When you can see, obviously everybody starts in the ICU. That's part of the inclusion criteria, but some are getting discharged very early, just a few patients. But you can see how patients are discharged over those initial days, and also how mortality rates increase gradually over time, become a bit more stable over certainly 30, 45 days. By looking like this as well, just want to point out that we're working with the stats team and NIHR. We think this sort of analysis, longitudinal analysis over time, gives us a lot more power than our original mortality rates at 90 days. And with our recruitment rates, it's quite clear to us we're not going to get to the total of the 3,700 patients that we planned at the beginning in any sort of reasonable time. But by analyzing this data, it's much more rich, much more informative. We think we still have the power to reduce our sample size down. We're still finalizing the final calculations, but it's likely we're going to need somewhere in the region of 1,300 patients now, we think. So remember, we're just over 500. So it's likely we can do that in a sort of 2-year period. So I just put that up to let you know what the plans are. It's not finalized yet, but I thought we'd share what's coming. So again, just so you can think about the trial, probably run for another 2 years or so. If we go to the next slide, we'll just show it for the GM-CSF population, which by definition, our inclusion criteria is a sicker group of patients. They must be either ventilated or receiving 2 organ support and show that signs of immunosuppression. And you can see here those categories, they're a much sicker group of patients. Mortality rates are higher. Patients are taking longer to be discharged to the ICU and get out of hospital. And so we have far more power in this group. There are more events happening. And so, again, we will do that same analysis, but I thought it was interesting. You might want to see these figures. So you've got a concept of what these clinical states look like over time. And so that was the update we were going to share with you about the trial. And I will hand over to, is it you, Ravi? Or one of the other team members to just tell you a few things about the processes in the trial, just as a refresher.
Thanks, Tony. Yeah, we'll all go through a couple of study reminders.
So some sample stats from since the beginning of the trial. So over 1,000 blood tubes have been collected and shipped to the central laboratory this year alone. And the central lab has issued over 290 PCR reports this year. Next slide, Ravi. So PCT collection. So procalcitonin should be measured on the day of inclusion or the next day, so at least 18 to 36 hours later. And both tests must be taken and entered onto Open Clinica for any patients randomized to the diagnostic intervention. And PCT tests are measured at your local hospital and processed at your local lab or using a point of care device. So our results. All samples must be sent to the lab, including the sample shipping form. And if any patient details are missing, so the study ID for the patient or a partial date of birth, the lab team will not be able to send through the result to you guys. And there will be a delay. So the date of birth is just the month and the year. And the central lab will only send reports to those listed on the sample shipping form. So if you have any new staff coming into the team, please could you update your template sample shipping form to make sure to include them as well.
So one of the things to look forward to in 2026. So in 2026, we will begin transferring our existing open sites from paper site files to electronic site files on the platform Florence, which is our EISF system. We have 9 sites that are already using EISFs on Florence, and all new sites joining the trial will use the EISF from the beginning. So that is one thing to hopefully to look forward to in the new year. Next slide, please. Thank you. So a quick reminder of the Christmas closure dates. So the last day to order IMP or any consumables is next Wednesday, which is the 17th of December. The last day for recruitment to diagnostic and fluid intervention is Friday, the 19th of December. A gentle reminder, the GMCSF recruitment will remain open over the Christmas closure, but no samples are to be taken or sent during this time. And sample collection and the recruitment to diagnostic and fluid intervention will resume from Friday, the 2nd of January 2026.
Thanks, guys. So just to prepare for the Christmas closure, we just ask if everybody could make sure that you've got enough sample collection kits, because there'll be a period of time when the college is closed and we'll be unable to send more out. And just to ensure that you have enough IMP stock in pharmacy and on ICU so that you can recruit over the Christmas period. It would just be good to make sure that there's no issues with logging into Open Clinica or sealed envelope. As the college is closed, we won't have much database support in terms of user accounts. So if you have any issues, please get in touch with us as soon as possible, and then we can just make sure it all runs smoothly. And then we will just stop the recording for now.